Hello, everyone. Can you hear me? Loud and clear. So let me share my presentation today. I'm Adrián Hernández. I'm from Spain. I'm the owner and founder of PIC Dental. And we are going to see today a little bit of how we created this technology, how we introduced photogrammetry in dentistry. I had the opportunity and the honor to do it in the past, 16 years ago, and now I am fully integrated in the dental community and very happy to share what we did and to also to share what are we gonna do in the future, right? So let me share my screen. Giancarlo's time, he's gonna talk about the clinical side. I just want to go about how we created PIC Dental, what is PIC Dental, and we are in Torrelodones, okay, in Europe, in Madrid, Spain, where the headquarters is. All the manufacturing areas are in Madrid in different locations, and the assembly and the PIC Academy is in Torrelodones, is my hometown. We have a small office in Miami, Florida. It's in this iconic tower. It's called Miami Tower, and it's in 38th floor. And we have done now 1,800,000 full arches in the world, which I'm very proud of. And we are present in more than 54 countries. So let's get to the point, as we don't have so much time today. We do have two types of implant platforms. We have direct to implant platforms, which is the PIC transfer, screwing in directly to internal cone, directly going into external. We have 2,700 different implant platforms that we are, which is almost every platform in the market, right? And we also have abutment level PIC transfers, which they work for all the transepithelial abutments available in the market. For today, we have a very specific one, which is the NEOS. NEOS has a very particular platform that works, is the same in the abutment level that the implant level, which is so nice, so easy to use. We also have two different sizes. We have the standard PIC transfer, which is working for the last 16 years, and also the PIC transfer mini, which is 2.5 years in the market, and it's just 30% smaller, same material, same accuracy, same everything, just the size is a little bit small. So we have two solutions. One solution is the PIC system, which we have several form factors. It's just a choice of what do you prefer. If you have a sole clinic, or if you have a chain of clinics, or if you are a DSO, or if you are a lab, depending on what type of business do you run, we will recommend one form factor or the other, right? So the PIC transfers, let's get straight to the point. This is a 6 all-on-6 procedure, and regularly we place the PIC transfers. The distal ones, we are going to place them palatal, facing inside, and the mediums and the frontal ones, we are going to place them buccally. sometimes we change this configuration. The purpose is to have the 4 dots of every PIC transfer visible, if it's possible, in one shot. You will see it's very, very fast. If the implants are very close together, you have 8 implants. I think Giancarlo is going to show some cases with 6, 7, 8 implants also. And you can take the impression in 2 steps, moving the PIC transfers or whatever. But the purpose is to put them, the distals in, the rest of them out, and to see as much white points as you can. This is an example of how fast it works with the gravity. This is real-time impression. That's it. That's this particular case. So again, six implants, it's about 2-3 seconds impression, right? This is probably the worst situation you can find. 8 implants in the lower jaw. By the way, we did in the past impressions to 13 implants. In some countries, they place 1 implant per root. So they place, the maximum I did in my life is 13 implants in the same jaw. But it's quite rare. So this is during the training. So this video that you are going to see is during the training of a customer. And this is how it works when you are working. So you want to go over the bridge to see all the white dots. And so this is, again, real time, 8 implants in the lower jaw. It's about 5-6 seconds, maybe. But we are not here to talk about speed, right? Velocity is okay. To be fast is not bad, but it's not the best. It's not the most important, right? The most important is to be accurate. And this is the key here, to be accurate. So we started developing the PIC Cloud in 2017 with a totally different algorithm. We started working with Microsoft, Android, and a specific phone because they have the best cameras in that time. But we weren't able to get the same accuracy that we achieved with the PIC system. So in 2020, we see a little bit of light at the end of the tunnel, and we see a way to, with a totally different algorithm, to be accurate, close to the PIC system. Because for us, it makes no sense if we are very fast, if we are very friendly user, but if we are not accurate, for us, it makes no sense to launch a new product, even if it's more cheap, even if it's more easy for the labs or for the clinics or for the surgeons. Is for me, there is no argue. Precision is and accuracy is the only thing what matters here. So it's a different approach. It's not the same approach as the PIC system. We have to take different pictures from a certain distance, and we are taking pictures with an iPhone Pro. Has to be an iPhone Pro. You cannot use Android or other phones. It's just iPhone Pro or Pro Max. And you take pictures from different perspectives, and the cloud is computing all that pictures in real time, and it's showing you can see here, you can see the progress. Once you get all, you can see different colors. Red color is you never see that PIC transfer. Yellow color means, okay, I have a picture, at least one picture where I see the PIC transfer. And green color is, okay, I have 100% accuracy on that specific transfer. So when everything turns green, suddenly appears that message, success. So you are done. You have a passive fit digital jig, right? And this is a totally different approach. It's not an investment in capital equipment. It's a pay-per-use case. Okay, an all-on 4 cost is $64. And this is very, very pragmatic way to entry. And the most important thing, it's for us as a long-term family company, it's important because you have a way to start to help you to grow your clinic, and you don't have to make a big investment. Once you are doing a lot of implants, we're talking about 500-600 implants per year. Maybe you want to go to get and invest in the capital equipment, or maybe in the future, when these times come, the pickup is as fast as the PIC system. You never know. Probably will. But today, the only difference between the pickup and the PIC system is one investment, one shot, and you can do whatever you want with your files, and it's very fast, very accurate. The pickup is the same accuracy, but is a little bit slower. So acquiring a six implants units, 6 implants, and around 6 with the PIC system is about let's say less than 10 seconds, and with the pickup is going to be less than let's say if you are very bad taking pictures, if you're a beginner, is 2 minutes. Let's say 2 minutes and a half. Okay, is the worst you can do. I personally am doing this in about 45-50 seconds. So you have different licensing. If you pay the annual subscription, it's 2 months for free. So we put a lot of easy access. So our purpose is to have in the cloud, where now we have a lot of different integrations. You can integrate with 3Shape. We are going to be integrated very soon with all the platforms. And from the cloud today, you can download not just the PIC file, but also you can download the libraries. So we do have 74,000 implant libraries, and all those libraries are in the PIC cloud. And when you use the every time you get a case, if you have different specific gingival scan markers, you can download that particular library for 3Shape or Exocan. So we built the first photogrammetry ecosystem in the world, which is just with the PIC system, the gravity, the station. All of them share the PIC camera, the PIC transfers, and the PIC suite, and the pickup and the PIC cloud. The PIC Pro is the PIC Pro training, is the most important. I guess Dr. Romero is gonna speak a little bit about how was his training in his facilities a lot of years ago now. And well, let me do a small introduction to the PIC Pro. So we are gonna take more than 30 topics divided in 8 categories to cover the full arch implant restoration. And we are not gonna just teach you how to use the PIC system. We also teach you how to properly take the patient records, how to properly use your intraoral scanners, your softwares, etc. Very important, the landmark alignment strategies. Even if you have natural landmark alignment, or you have to place an implant or a mini implant or a fiduciary marker, we create so more than 15 years ago, this type of strategies, if it's a lower, if it's an upper, if it's zygomatic implants, it's not much more complex. It's easy. Shortcuts, very important. Shortcuts for the different softwares. Very, very important. How to avoid wasting time with 3D printers or milling machines. How to go straight to the point, being precise and consistent. The manufacturing side is very, very important. You can be very accurate taking the impression, but if you don't have the proper, let's say, titanium milling strategy, you're gone. So your connections has to be very, very well. Prosthodontic workflows, treatment protocols, all this training is very, very important. So we do 1 to 3 to 5 days training in the clinic on site. Okay, and we will teach you all the way from zero, from A to Z. Important points like this. This is probably the most important, is the starting point. And today is becoming rare to start with a WhatsApp, but it's so let's get on. I don't want to be taking the time from Dr. Romero, so I wanna go directly to the clinical side. Please, Giancarlo, if you want to continue, I think as an intro for the company, this is okay. Maybe if you wanna go and show your clinical cases, I'd be more than happy.
Perfect. Can you go ahead and let me see here, go back to the main screen. So once again, thank you for the putting this together. I'm going to talk about my experience and the experience with PIC when I started with photogrammetry. I mean, many years ago, probably about 10 years ago. And I met Adrián. Even though there is a lot of technology coming out, you have to be very skeptical what you're going to incorporate into your practice, because it has to make sense, not only financial sense, but it has to make sense with the efficiency that you're going to use this technology. And the first thing that when I wanted to get introduced into photogrammetry with Adrián, he said, you have to close your practice for 5 days. And I said, you're crazy. How can I close the practice for 5 days? I can't do that. And after I made that decision of closing my practice, it was the best decision that I made for the last 25 years that I've been doing dentistry, prosthetics, and implants. And it's for the fact that I was very digital. I thought I was very digital because I had a scanner, I have an in-house lab, I have milling machines, I have 3D printers, I have face scanner, but I was missing something. And what I was missing is I was still taking impressions intraorally and doing jigs, which it makes no sense in this world if we're doing implant dentistry. So I'm gonna kind of fly on this. So if you see this slide, the PIC system or photogrammetry was the missing link in my practice many years ago, because now this puts everything together that I can work more efficient on my cases from the day of the consultation to the final delivery of the prosthetics. And the cases that I'm going to go through is going to show this. So I want to stop here because a lot of people has the misconception that having an intraoral scanner, you can do a full arch case, and it is not the case. It is not the case because intraoral scanners have limitations. And if we scan from one side of the arch to the other one, you can get a discrepancy of easily 250 microns that was established by Capsuli in this study. And we know that micro or fitting or passive fit has to be within 100 microns. So I was doing this before, and I was struggling a lot because I was a skeptic of number one, to go into the technology, number two, to do the jump, to spend and commit my practice to spend this amount of money on an equipment, which today there is no reason for holding back. There is no reason for holding back, just for the fact that having photogrammetry on your iPhone is a game changer. Before, the excuse was, well, I don't want to spend this amount of money in this equipment because it's too expensive and I only do a few cases. But now with the iPhone, there is no excuse not to do that. Like Adrian was saying, is the key part on photogrammetry, or the PIC Pro, let's call it, is to understand how you get to point A to point Z, keeping landmarks from the pre-surgical phase of your case to the final delivery of your case. Is when I closed my practice for about 5 days, is when I understood the workflow. Is not because I have photogrammetry. Photogrammetry, the machine or the iPhone is not going to do it for you. You have to understand the process. And if you're going to take something out today, is keeping landmarks from the day that you take your initial impression or initial scan to the final scan for your final prosthetics. So from the financial part, and I'm going to break down, analyze the analog world. When I used to do the analog work, it's very time consuming, unpleasant patient experience, not accurate, less cost effective, and poor anatomy on the conversion prosthesis. Before photogrammetry, I would spend with lab work, with all the consultation, with surgery, about 16 hours to do a case, which if I charge 35 grand per arch, that I would only produce 2,200 an hour. Now, with digital and specifically with photogrammetry, now I'm very efficient. Patients love the experience. And they love the experience because they see all this technology. They don't have to take an intraoral, they don't have to go through an intraoral impression. Is the most accurate process is the PIC system in the literature, and it's very profitable. It's very profitable because now the same case, I break it down in 5 to 6 hours. 5 to 6 hours now, instead of producing 2,200 an hour, I'm producing 6,300 an hour. It is not only about the money. It is about the quality of work that you're providing to your patients, and in less amount of time. So that is what it's all about. So the different type of, in the cases that I'm going to show today, we're going to show about FP1 and FP3 prosthesis. And I'm going to break down on these two groups, what type of connections or what type of final prosthetic you can request the lab to deliver to your patients. The one on the left-hand side, the one that has tie bases, is my less favorite. It is the less favorite because if you're using tie bases, you're going back to a problem. You're going back to a problem because now you have to glue the tie bases to the zirconia that has been milled, and there is going to be some misfit, horizontal misfit. So you're not doing, or not, you're disturbing the purpose of photogrammetry because now you have to glue the tie bases. You're introducing misfit. If you're going to go full zirconia, that is actually my second option, with new zirconia that is out on the market, that are very strong. They're up to 1900 megapascal. You can mill directly to the platform out of zirconia. If you're working on FP1, it could be a little bit fragile because of the connectors, okay, even though you're using a very hard zirconia. The one on the right-hand side that is my favorite or my preference is to mill a titanium bar or an skeleton that then is going to be have received a zirconia coping that are the teeth, and then you glue the two pieces together. Why is it my favorite one? Because from the PIC file, from the photogrammetry file that only captures the implant position, you can mill the titanium puck that is going to be very precise to that file. So the amount of steps are reduced, and you do not have to cement any tie bases. So I'm going to start with this case, and I break them down in dentate and edentulous. So a dentate case, this case comes to the practice with a severe resorption on the mandible, posterior mandible, which we decided to do FP3 on the lower, and we preserve the upper teeth. So this is the workflow, and I will share, Emily, I will share the PDF of this presentation so you can pass it around. So people have a handout of what records they need to take depending on the situation of the patient. So we take intraoral scans, we take bite, we take a cone beam, and we use a face just to design the future prosthetics for the patient. And then during the pre-surgical and the laboratory workup, my technicians are doing the digital extractions and doing a setup before the surgery. Now, I want to be clear here. You're seeing, you probably see a lot on social media, magazines about the clip-on technique, okay, or the stackable surgical guides. For me, that is useless, okay, because we spend so much time on reflecting big flaps in order to accommodate these surgical guides. And on the preclinical, this setup that we're doing, we're going to use it after the surgery. From this setup, you're developing surgical guides. So surgical guides, it's up to the preference of the provider if they're going to use fully guided or if they're going to use pilot drills. But there is no need to do any stackable guides because we're not delivering a pre-made prosthesis and then picking that up in the mouth. That's too much work. So then at the day of the surgery is done. And I want you to see on the center pictures where you see that we leave number 18 and we leave the tissue untouched on the left side, on the right side of the patient, because these are going to be my references to stitch the pre-surgical model to the surgical model, okay? And then we proceed to take the records of photogrammetry with those landmarks, and then we take either intraoral scan the day of the surgery with the teeth that are references as landmark or the tissue that has not been reflected, so we can go back that model and stitch it to the previous model. And this is, I know it's confusing, and this is where the important part is of the training. It's not about buying a machine, it's about training your stuff. In my practice today, I don't, if my assistant they do not come the day of the surgery, I cancel the surgery because I'm ignorant about setting up everything. The pro system or the PIC system, they train your staff how the workflows works, okay? And that's efficiency. So after you proceed with the surgery, you remount the surgical model that has the landmarks, and it has the landmarks from the teeth to reorient to the pre-surgical one. And then it has the landmarks of the healing abutments that are going to be useful for stitching your photogrammetry data. Then we transfer the previous design, we transfer that to now the new mounting the day of the surgery, and then we milled or we 3D print. Today, you see here on the screen on the right side that I'm using tie bases for the mill. I don't use that anymore. Okay, that's a little bit too much. There is no need. Now the libraries that are available allows you to mill the connection with a taller screw that is very, very resistant for those 3 months that the patient is going to be using the temporary prosthesis. I either deliver a 3D printed the day of the surgery or a milled prosthesis that is my preference the day after. The reality is the surgeries that we're doing, these are surgeries that take 2-3 hours, and the patients is on IV sedation. The patients get a little bit tired. I'd rather the patient go home, rest, and then in the morning they come in and I deliver the prosthesis. Delivering the prosthesis takes me no more than 10 minutes, okay, believe it or not. And the patient's still numb because you infiltrate them with Exparel, or you have some mouth rinse that are anesthesia mouth rinse for the patient. So this is the same case after the day after that I delivered this, and the patient on the maxilla is receiving some Invisalign, which we proclinated those teeth in order to keep them and to kind of jump the end-to-end bite and create a good result for this patient. So after 3 months, we go ahead, patient has healed. We go ahead and do the photogrammetry again. At this stage, we retorque the multi-unit abutments because most of the time you're gonna feel a small movement. And then we take the records intraorally. Now, there are 2 records that are crucial here. Record number 1 is the photogrammetry that you see on the left side. That is only taking the implant position. Record number 2 is your intraoral scan. Your intraoral scan only is useful for your tissue and to orient the healing abutments that are my transfer at this stage. You could use scan bodies, you can use healing abutments. PIC system has thousands of libraries that you can interrelate in order to stitch images together. And then we fabricate the final prosthesis with a metal bar and then the zirconia that goes cemented on top. And then we have the final result on this particular case. This is another case where patient has severe wear. And this took me a little bit longer. The usual case, it shouldn't take more than 3-4 appointments. This took a little bit longer because of the bruxism that this patient had. And I did not want to load the maxilla at that point because I didn't want to risk the implants. So we went ahead and temporized him first and on the teeth that I'm going to remove. So I did what I call a sequential extraction protocol on this case. So in one day, I could give him some function, some aesthetics. And then this helped me to create an outline of what my future restorations are going to be. And now I can start planning my surgical guides, okay? So from this planning on these temporaries that I already did that are already on the patient's mouth, I went ahead and fabricated my surgical guides. In this case, I did fully guided. The fully guided, because of the fact that this patient has a massive amount of bone, and we drove those implants in, and we temporizing once again with the teeth because I didn't want to load those implants. And then when we got to the final state, we use the sequence of photogrammetry in order to take the records of the implants. You can see here the access abutment, but now NEOS has multi-unit abutments. And this is an FP1, a little bit more tricky to execute because the implants have to be dead on the position that the teeth are going to be. And the rotation of the implants has to be dead on. And we went ahead and took our PIC records. We took the healing abutments records for the tissue, and then we took the intraoral PIC transfers. So we're doing a full arch impression, capturing the PIC flags and PIC transfers, and we're using photogrammetry for an FP1. This has changed, it's a fully digital workflow, has changed completely the way we do dentistry, especially with the gravity system, with the PIC gravity system, which we've tried from first generation to the gravity system today. We're gonna go ahead and capture 7 implants of this type of thing. And this is how quick it is. Capture with the gravity system. There are 7 implants. A ver, grande. Eso es. Manténme abierto así. No te vayas a mover, por favor. As soon as I put it, we start getting captured. You see on the left side how it rotates. So it tells you which ones are capturing, and then you can move a little bit. 1, 2, 3, 4, 5, 6, 7 implants on this case, and it's done. Most of the time it's a little bit faster. You can do this. And then after we got all the data, we go to exocad with our technicians and do the final design of the FP1. And he had some old implants. We kept some of the proprioception of the lower teeth. And that's the final result on this case. So this is a very extreme case, okay? It's a patient that, thanks God, he was in rehab and he could surpass his addiction, and he's still sober. I mean, he's good right now, but he got to a point in his life that he was losing all his teeth, and he was fortunate that his parents helped him to pay for this treatment. And I'm more into the FP1s than FP3s if I can preserve the bone of this patient, especially young patients. Because I don't like to remove bone if the patient doesn't need it. So take all the sequential of the photograph, and we do all the planning. This is all the record that is taken. The first appointment on the patient is a protocol that has been established many years. And then we do the design, and we know exactly where the implants are going to be placed. But the same situation, this patient, because of his addiction, had to go through a bunch of medication that he was taking, and it would increase the risk of failure for immediate load in this case. So we did some sequential extraction as well. So I rebuilt some of the teeth. I did this case with a periodontist, and we analyzed the position of the implants, and I'm going to kind of jump into this. We temporize the patient, and in the maxilla, we place, I believe, with 5 implants. In the mandible, we place 6 implants. And then things that are crucial in the maxilla is going to be preserving your root gates, your tuberosity areas when you're taking these records at the surgical phase, because it allows you to merge pre-surgical data with your surgical data. In the mandible, it's a little bit more, it's harder. In a full arch, you have to preserve the retromolar pads, but we preserve teeth to be our references to stitch to overlap models from the surgical to the pre-surgical phase. And 1, 2, 3, 4, 5, 6, 7 implants on the maxilla on that left case. And so if you see the right screen, this is what the PIC files are going to look like. You can put on top of it anything. You can put healing abutments. You can put scan markers. The system allows you, is so versatile that allows you to pick and choose whatever you want to use, whatever is in your practice, okay? And then we fabricated temporaries on him. And now we move to the final state. The final state is on the left side, patient with temporaries. We preserve landmarks. In a final impression, landmarks are crucial. Keratinized tissue. Keratinized tissue is one of the most important that you have to capture, because you're not doing surgery at that stage. So if you take, for example, on the lower, many times when my assistants are taking the pre-op or the temporary intraoral scan, they miss some keratinized tissue. They only take the teeth. So we have to go back and make sure we get all the landmarks of the keratinized tissue. So we can stitch the image that you see in the middle, that is the soft tissue that does not have the teeth. We can stitch that model of the soft tissue that carries the markers of the PIC, what is going to be stitched to. We can stitch it to the temporary phase. And then my lab finalized the design, and we got 7 on the upper, 6 on the lower. And then he wanted, one thing that he made me promise is that I make gold teeth for him, because he had gold teeth before. So I put 2 gold teeth on him, 2 facings of veneers. If you see, I'm using tie bases. This is an old case. If I can avoid using tie bases, because it deserves the purpose of photogrammetry, you have to do some more extra step if you're going to use tie bases. Today, we're doing it with titanium bars that are incorporated into it. And you can see here the x-ray, the quality of the bone, the stability of the bone. This is a new system that I did many years ago. I'm pretty happy patient. And then, so this is another case where, let me hide this. Okay, well, this is another case. A patient comes with a lower denture and upper partial. We could have preserved some of the upper teeth, but after a discussion with the patient, we decided to remove those teeth. And if I can preserve, I preserve, but in this case, we remove. So these are the records. Once again, photograph, cone beam CT, ray scan, that is a 3D phase for design, intraoral scan of the real situation. And then we take these 2 digital smile design in exocad in order to design the position of the teeth. The lab phase on a denture, you scan the denture fully, intaglio and chemio surface, or you can do a cone beam of the denture with some fiducial markers. And then you can create a model from the same denture that you scan, or you scan the soft tissue. Soft tissue is a little bit harder to scan. So if you scan the denture, that you reline, making sure that denture is fitting precisely on that soft tissue, then you can generate a model for the soft tissue. Then we approve the design. We went ahead and prepared the maxillary teeth for a temporary. And then I start fabricating my pilot guides, and we went ahead in the maxilla. We decided we're going to do an FP1. In the mandible is an FP3 due to the resorption this patient has had. in the past. So this is my planning. I'm placing 6 implants on her, doing the surgery. And I'm going to jump through this because of time. I'll share this presentation with you guys, and you'll get it via email or WhatsApp. Then we go back to the surgery day. So the surgery day, on a edentulous case, because you can use retromolar pads as references. You can use surgical implants as references as well. That are mini implants that you position strategically around. You scan before the surgery, and that's your pre-op model. And then you scan after the surgery when your implants are in. That's your surgical model that you're going to stitch together. But you can also position, in this case, you position your healing abutments over the multi-units. And then I do a reline, and that reline helps me to, number one, already transfer my bite against my fixed maxilla. Number two, it helps me to create a soft tissue impression, digital impression, because now I scan completely the denture, intaglio, and chemio surface and generate a tissue with a reverse inverted software of that denture, and it creates a tissue. So that helps me to already maintain the vertical prior to the surgery. And so it is a workflow. In this case, we did a 3D printed. We incorporated some type bases. Once again, these are cases a little bit older. And the maxilla, we did not load. We only preserve teeth in the temporary phase. But you can see the fit of the bite. There is a protocol that if you keep that protocol, you're efficient and you shorten the amount of time of your procedure with a better predictability of your cases. Then after 3 months, we exposed the implants, and we proceeded to take the teeth out with a new temporary, taking a PIC file, and then we fine-tune the temporaries in order to create an FP1 approach. And let me jump this, and then we fabricated a lower temporary for this patient to validate. And then we jump into the final state, where the final state was a full zirconia prosthesis on the maxilla and a lower bar on the mandible with a very predictable. Now, going back again, what makes it the company, even though I'm a very good friend with Adrián, let me make it clear.
It takes about 9 photos.
But that is because of what he has created.
To make it to focus on the middle of the screen to take your first photo. And then take one from the bottom over here. Then one for open a little bit from the top.
And not only that is what PIC system has created into our industry. For me, after Brandenmark, Adrián is gonna pass like one of the most influential person in the implant dentistry, because once again he created something that was a missing link in my point of view. Another case, patient came many years ago with periodontal disease in the mandible, maxilla. On the mandible, we did the workflow of impressions, and then we designed it, the prosthesis. We created our surgical guides, and once again, the key point is preserving landmarks during the surgery, so you can interrelate models, digital models. This was the old system. That's an old case, a very old system, which still works very good. We use it for our lab. So what you see on the lower right is what the PIC file comes out, and we relate these healing abutments to what we took intraorally. And then we transfer the prototype that was designed previously, and then we deliver the temporary prosthesis. And this is a final on her. We finished our case with an FP3 on the lower. But the interesting part on this case was we finished the lower. Patient goes to Dallas. She comes from Dallas. I'm in Houston. And I sent her to a periodontist to treat the upper one. I sent her to a periodontist, orthodontist, to do soft tissue to manage the periodontal disease. She comes after 3 years. She did nothing, okay? And now she wants to move with the maxilla. And we do all the records. We do digital smile design just to reorient the position of those teeth. And we create a surgical template for the surgery in this case. And in one day, we place 6 implants in the maxilla with temporizer. And we redid the lower one because now she wanted lighter teeth, okay? And after 3 months that we are extracting the maxillary teeth, we do the PIC files. And my references here are very easy because are my teeth, okay, with healing abutments, and then the maxilla edentulous with the healing abutments. So I can interrelate everything in the root gates. And after we created a surgical an exocan design, we redesigned the maxillary teeth again according to the position that we wanted in her face. She heals for about 3 to 4 weeks, and then I'm ready to proceed with the final impression. I worked this case with a good friend of mine from Italy to develop the final prosthesis. And then on the final prosthesis, this is a sequence of scans that needs to be taken. And this is what we're designing today. This is probably the top of the advice that I can give you when you're doing FP1s or FP3s, that you do blender, or you ask your lab to do blender, because it's a metal structure and then the zirconia goes on top of it. So the precision that you're milling this titanium to your photogrammetry data is exceptional. Is the way when you deliver this, the screws, they feel so loose to go in without any resistance, that you know that you're obtaining a very precise passive fit. This case, if you see the lower right, that I have zirconia frame. This is a new zirconia that I was talking about in the beginning of the presentation. It resists 1900 megapascal. So this is probably option number 2 for me, okay? And I'm starting to use a lot of this because of the quality of the aesthetic of this material, because then you're going to overlay it with copings of zirconia on top of it. And so this is a final product for her, okay? And I think it's a big change on this individual from the start to finish. And this is a patient that lives in Dallas. It took me 3 appointments to finish, okay? 3-4 appointments to finish. This is something that I always tell when I give a presentation. Before PIC, I was miserable. It would be Sunday and I didn't want to see my schedule, because if there was a conversion prosthesis that day, I was miserable. I didn't want to go to the office because I knew I was going to be dirty. My staff was going to hate me because I was not in a good mood. Today, because I'm doing photogrammetry, I'm not doing almost anything impression intraorally is a efficient, clean workflow, I'm happy. I know I'm not going to struggle. I'm not going to struggle to take intraoral impressions. Very interesting case. 2011, I did 4 Neos implants on the maxilla, and because of finance, I ended up doing a denture for her. And this year she came. So this is 2011. You can see the upper 4 implants with a bar and an overdenture that I did. And then she came 2026. Again, came this year, the beginning of the year. Now we're treating the lower mandible, and we removed the teeth and did the workflow of photogrammetry. Now, if you see the picture on the top left, I have my 4 implants with my pilot drills. I'm placing those 4 implants, but I'm not removing the 2 canines, because my 2 canines are gonna be the reference of that surgical impression, surgical model to my pre-surgical model. Okay, so that is the importance of keeping references in order to translate your vertical dimension. I took a model first of the denture with how she presented, and took my vertical. Now I'm doing the surgery. I don't care about the vertical, because if I keep the 2 canines, now I can grab that surgical model and stitch it to my pre-surgical only by my 2 canines. And my vertical has been transferred completely, okay? And on the lower, we did a FP3. On the top, I converted the patient to an FP1. The beauty of not only photogrammetry, but the libraries. Adrian, I did this case now, but I used a library that we created, or you created for me. I didn't do squat 8 years ago, because when Adrian and myself met, I was strictly using Neos. I'm still using Neos, but I was strictly using Neos, and there was no library. And then this is the value of having a good company backing you up, because they develop the library that I had the opportunity to use it again for this case. And on the picture, that's the day of delivery. The tissue is still inflamed, and I saw her this week, and now everything filled in. And you can see the milling. This is also going back on the Neo system. You kind of touch on that, Adrian, because with the Neo system, you can use the PIC transfer, the flags. I don't want to call it the flag, but it's a PIC transfer, that you can use it directly to the platform, or you can use it to the access abutment. Now Neos has the multi-unit abutment, that you can use it also as a multi-unit, okay? So you need a different flag for this. And I think this is the last case. I know I'm running out of time here. Patient is edentulous. If you see, patient has been without upper teeth for easily 10 years. He's a guy that does a lot for the community. He preaches, he helps the community. And so if you see on the left side that I have a wax trim, that is the principle of the beginning of the setup, where the teeth are going to be, and the beginning of where my vertical is going to be. You have some fiducia markers on this wax trim, those little white dots that you barely see there, but then you see it on the panel, you see it on the scan, because now I'm transferring the position intraorally of the wax trim to my scan. And then I can transfer my setup of the teeth to my scan, and I can fabricate my surgical template. So do my surgical guide with pilots. If you see the model in the middle, has the 2 canines still, because that's going to be my reference for the lower one, how I'm going to transfer that surgical model to my preclinical model. We start the surgery, we remove the 4 teeth, I place my 4 implants. In this case, I'm very particular when I reflect flaps because even though I'm going to level a little bit the bone because it's an FP3, but I only level the bone in the anterior area just to place my implants, okay? But I preserve my canines because my canines are crucial to transfer the lower right model at the end of the procedure to my pre-surgical to preserve my vertical dimension, okay? And then I can remove everything. I can do my peak capture, and now I can stitch my data, my peak position to my surgical model, and I can design a milled prototype. If you see, there is no type base. These are newer cases in my practice. This is a way that I like to mill, so that's why I deliver the next day. And we delivered that the next day for him on the maxilla. He has with the denture. I didn't want to really push the limits of trying to do an immediate loading on him. Then we put a temporary, actually I did an immediate loading. Then we put a temporaries, and then we fabricate the final prosthesis for this individual. So from start to finish is a big change, only about 3 or 4 appointments. And it's not only 3 or 4 appointments, it's a better quality of work that I'm going to provide to the patient. That's the bottom, that's what I'm looking for. Better quality is not because I'm making more money in less time, it's about the quality that I'm providing and the experience that I'm providing to these patients. I hope I didn't rush too much. You can probably, if you want to reach me out, here is my information. You can ask Neos about my information. I'm gonna go ahead and share some PDF in these coming days with Neos so they can get it to you. And thank you for the opportunity, Adrián. It's always a pleasure sharing the podium with you. So I leave now, Emily, for any questions that you might have.
Well, it helps a lot. It's like when you have in the clinic, and this is something we face every training when you are doing a training in the clinic and they have 6 different screwdrivers, 5 different type of transepithelial abutments, 12 different healing caps, cover caps. It's it's not helping. And the more simple and the less number of materials you have, the more efficient communication you give to your assistants, your auxiliaries, and also to your associates. It's very easy when your clinic growth, and this is something I'm very proud of. I have 86% of my customers. They purchase a second unit, meaning they grow, right? So this is very important when you are gonna grow because of you build a very efficient process. In that process, believe it or not, we shorten the number of stock material in the clinic, and that's a key point.
Yeah, as a provider, simplicity is very important. I know Neos has that slogan for many years. Simplicity has the same platform. That's one of the reasons that I merged with or changed to Neos many years ago, because now I tell my assistant it's a Neos system, it's a Neos impression. It's not a bi-horizon, yellow, conical hex, and this and that. So it's the simplicity. We only standardize to one platform, that is the multi-unit platform, pretty much. The smartphone and then the device is just a device, okay? Is not going to show you anything. The key point here, out of my almost 30 years in practice, that was the course that was the most beneficial, important to what Adrian is saying about the growth. Okay, not only from the intellectual growth that you receive and you feel, but also from the growth financially, because your practice is going to explode. And believe it or not, when you're doing things in a simple way, because you understand it, your brain gets more rest, and you start thinking about some other things to do, either financially or for your family. Yes.
So we faced, of course, 16 years ago when we started, the digital workflow knowledge and implementation in the Dupla clinical lab was very, very few comparing with what we have today. The problem is that 10 years ago, the clinics that they feel they are digital experts today is the same feeling. No, I am a digital expert because I have my DSD, I have my intraoral scanner, I have my face scanner, but they don't understand, they don't see the matrix in between. And sometimes uh, we see a lot of customers, they don't want to get the training. We're good. We are going to reach a point, the training. If they are 5 days training or 3 days training, they are going to do between 12 to 16 full arch patients in 3 to 5 days. So the next Monday, they are fully autonomous and with the confidence that they already deliver more than 10 full arches, right? And that's the key. The key is the confidence. Are you going to spend or are you going to invest in 3 days training to reach a level that you never get, or probably you need 2 or 3 years to reach that point? It is worthy to wait 2 years. In my point of view, it is worthy to learn. I don't know if it's 3 days or 5 days or half a day or online, but try to learn. But it's okay. It depends also on the character, everyone's team, the age of the team, the knowledge, the expertise. It's not easy.
Well, in my particular situation, I probably 10% print them, and 90% I mill them. And the fact is that to do a 3D print, sometimes the technology of 3D print, depending on what printers you're using, it can misfire and create an issue. But since I have an in-house, I'd rather do a PMMA, and I do a PMMA because I have less fracture with a PMMA that I've had with 3D printing. Okay, the 3D printing is so rigid that it fractures easier, okay, than a milled prototype. So within the protocol is, for example, if I'm doing surgery on Friday, I 3D print the prototype, we deliver that to the patient, and then the next week we swap it for a PMMA, because we know with the PMMA we won't have issue with fractures, and it's gonna stay there for 3 months without any issues. It's a big advantage from what my experience is, because I've worked both systems. I work what I call the contact lens screws, and I work the neo screws that are real size prosthetic screws that you can really increase the torque to 32 Newton centimeters. So the usage is probably the feel is the same, but the sensation that you're torquing prosthetic screw to 32 newtons, and because your final screw is it has that gold Teflon, let's call it this way, I've had less issues with that screw, or barely no issues with that screw, than the regular prosthetic screw for multi-units. Way that I see implant dentistry, all on X, is kind of a mixed match, and it's a mixed match because we're over treating patients, okay? Sometimes we're over treating patients because we forget that teeth can be safe in a predictable way, and we're pushing this too much, okay? That's how I feel. Number two is the problem is that it's not that we're pushing it too much, is we're pushing it to providers that don't want to take the time to train themselves. And that's a key point for me. When there is a symbiosis and a point that people want to get trained properly, then I believe the practices in the future, there is not going to be one practice that offers implant dentistry that does not have an in-house lab, okay? Because the population is becoming so smart. Well, I think they're becoming smart on Google, and they come requesting things to your practice that I didn't ever see 10 years ago. They request zirconia implant, they request Olonex, how many implant they think they need. So it's a kind of a combination of this metamorphism that is happening in the industry, but I see in the future all practices have to have an in-house lab and with fully digital.
100%. Times are changing. When I built PIC 16 years ago, I did it because of my father. My father needs a restoration. It was broken. I have to, the doctor and the lab has to rebuild the prosthesis from scratch. And I think, wow, this is a very inefficient process. So I built PIC and the PIC Pro to help my father. But the app is to democratize the technology. So I think our protocol, our prosthetic process has been copied by thousands of doctors and companies, and adopted by hundreds of companies, and I am very proud. So yeah, we started to help just one single patient, which is very special for me. It's my hero, my father. But the pickup is here to democratize the technology, no doubt.